The more that you read, the more things you will know. The more that you learn, the more places you will go. A very good morning to one and all present here. We welcome you all to the Charm INGENIUM workshop. After the successful conduction of Charm Asia offline workshops for the past 4 days, we now proudly introduce the next phase of Charm 2023, the INGENIUM, the webinar week. We start the INGENIUM webinar with today's session on urinary incontinence, management and case discussion by our host speaker, Dr. Srikala Prasad ma'am. I take this opportunity to introduce our speaker, Dr. Srikala Prasad ma'am, Professor and HOD of Urology Department, Chengalpet Government Medical College. Ma'am has 32 years of experience in obstetrics and gynecology and 23 years of experience in urology and urogynecology. She was the past secretary of OGSSI Chennai and a nominated EVA member of Asia-Oceania Federation of Obstetrics and Gynecologists. She has organized various urodynamics workshops and live operative workshops. She has also authored various urology textbooks. I now invite ma'am to enlighten the gathering.
Good morning and welcome to all these wonderful MBA students. Why are you all in the back row? Why don't you come a little in front? Wherever you are comfortable, but we'll try to give you a bird's eye view of the problem of urinary incontinence. During this lecture, just to keep you awake, in between, I will ask you some questions. And if you answer what is in my mind, I will give you small. Okay? So now, we are going to talk about urinary incontinence. Now, does anyone know what is urinary incontinence? Can anybody define? It may be little too much for you, but what is urinary incontinence? See, all of you are continent. As you are sitting here, you are able to control your bladder, your bowel, your incontinence. But this incontinence means there is an involuntary leakage of urine. Without your control, it leaks. Can you put a phrase to the picture which I have put? What iceberg? Tip of the iceberg. What does it mean? It is trying to tell you that the majority of the patients who are actually suffering from incontinence do not come and tell you. So the majority are submerged. So unless you ask leading questions, they will never come out. So there is a gross underreporting. Now, involuntary leakage of urine. But I have used the word common and potentially debilitating. Can you tell me how urinary incontinence can be common and potentially debilitating? Leaking few drops of urine, how can it become potentially debilitating? Anybody? Louder. So we have now bothered about, I actually put pictures, then we'll see. Is the next slide? Okay. I will come to that again. I'll show you a picture. So why is the tip of the iceberg phenomena? See, if a baby leaks urine, there is no shame. But an adult, they will be really embarrassed. They would be ashamed to admit that they are leaking urine. So what do? They suffer in silence. And many of them, many of the patients and many of the treating doctors think it is part of aging. So the number of people who actually get treated for incontinence is very less. And as usual, they are afraid of surgery. Next slide, please. So as a result of all this, there is gross underreporting. Next slide. Okay. So what are the different types of incontinence? Stress. When you mean stress, it is not emotional stress. It is, we talk of conditions which can cause a raised intra-abdominal pressure. Tell me a few conditions which can cause a raised intra-abdominal pressure. Coughing, correct, lifting heavy weights, coughing, laughing, sneezing. These are the conditions which cause a raised intra-abdominal pressure. So the patient will be continent throughout, but at the particular moment they have a cough, they leak urine. So that is called stress incontinence. Urgency. Can you define urgency? See, I told you, even if you are, one of you, or when if you feel like passing urine, or she's taking class, another 1 hour, let us be here, you can control it. But if it urgency is defined as an urgent desire to pass urine, which is difficult to defer. The moment a person thinks they must pass urine, they have to be passed. Otherwise, they leak the entire quantity. So the difference between stress incontinence and urgency incontinence is, in stress, when they cough, laugh, or lift heavy weights, at that moment, there will be momentary loss of few drops of urine. When there is an urgency incontinence, the moment they think of need to pass urine, they will leak the entire quantity. So there will be a large volume leak. The next slide, please. Mixed is both. Many don't come with single separate dish. They have both. The next. Overflow. See, whatever I am talking may not really come to you in your exam, but it will be definitely useful in your whole lifetime. So, and you may not be having a class on this. So try to just listen what I am talking. Okay, ma? Mixed incontinence we talk when they have both. Overflow. Can you give me some example of an overflow? Why does there an overflow incontinence? Enama? So overflow incontinence is the bladder is full, both the kidneys are draining. If there is an outflow obstruction, say for example in men, benign prostatic hypertrophy, or in women maybe a prostate or some BOO, we call a bladder outlet obstruction. If there is a bladder outlet obstruction, the bladder will distend, and even if they pass small quantities, whatever is accumulating can leak, and that is called an overflowing quantities. Next slide. Functional. We skip this. Next slide. So what are the other kinds? Fistula. I have written VVF. Can anybody tell me some important causes of VVF? No. Prolapse surgery can cause. So, gynecological surgery can cause a fistula. What was in my days? What was the important cause of VVF? Now, because of the improvement in obstetric care, we have a lot of this 108, there is no delay, everything. The number of obstructed labor has come down. So earlier, obstructed labor causing VVF was common. Now, gynecological CA cervix and radish. The next slide is bedwetting. So this is the type of urine leak. Well, throughout the day, the child is all right, but at sleep, when the child is nicely sleeping, they wet the bed. Next slide. Ectopic. Next slide. Now, this is the first scenario. A 15-year-old Miss R. Actually, when I am working in KGH, this is a live, real case. A girl was referred to us by her school teacher, a government school teacher, somewhere of Minju, because her classmates objected to her studying with them, because they were not able to tolerate the constant urine smell emanating from her. So this is the 15-year-old child. Now tell me the diagnosis. Enema? Overflow. Overflow is not very common in this. Very good. One penalty. Wow. Come. Next slide. Next slide. Next photo. See, here you can see there's an ectopic ureter. One ureter goes into the bladder and the other ureter goes into the vagina. Once it goes into the bladder, you have a sphincter control. But if it goes into the vagina, the child has no control. So this is the poor girl who did not have the means to come to us till the age of 15. She has been suffering, and one school teacher recognized the possibility that she could be corrected. So anything younger, think of congenital cause. Next slide. So case scenario 2. An LKG kid brought their parents with complaints of bedwetting. Next slide. Next slide. Next slide. How do you approach? When are you worried about bedwetting? So we are not going to start treatment for bedwetting when the child is 2 or 3 years. We can wait even up to 5 years. Next slide. So nocturnal enuresis or bedwetting is defined as discrete episodes of urinary incontinence during sleep in children over 5 years of age in the absence of congenital or acquired neurological disorders. Even in children, they can have neurologic causes, neurogenic bladders can also be there. So if there is no ectopic ureter or any congenital cause and there is no acquired neurological disorders and the child wets during sleep, we call it nocturnal enuresis or bedwetting. Next slide. So, what is very important is you all will get married, you will have children, and I always say, no, the rest of the world will come to you for asking questions and doubts. So at that point of time, you cannot Google. So if you must be having a fair idea. So we divided into primary enuresis and secondary enuresis. Primary enuresis means children who have never achieved a satisfactory period of nighttime dryness. That accounts for around 80%. But secondary enuresis with children who develop enuresis after at least 6 months of nighttime dryness, and that accounts for 20 to 25% of total enuresis. So here, this is what it. Now again we differentiated into primary and secondary. And the second thing is you have to differentiate into monosymptomatic enuresis and non-monosymptomatic enuresis. Monosymptomatic enuresis only bedwetting, no other symptoms. For a daytime enuresis, pain frequency, we can give time. This child need not undergo the entire investigative cystoscopy, urodynamics, all that. We can take time to treat. But if the child has other things, we need to take it for. Next slide. So this is, what I wanted to say. If you follow the graph, 5 years na 15%, 10 years na 5%, but by adolescence it comes to 1 to 2% without doing anything. It's called masterly inactivity. Become moderate. But what you need to remember is, if you don't correct that at all, if you see, for example, we see sometimes software girls also come at the age of 25 with bedwetting. At that time, the bladder-brain dialogue is well established. Little difficult to treat them. So you must encourage toilet training in child, in babies. The attitude of putting a diaper onto the children, onto the kids and leaving them. The mothers are not bothered. They buy packs and packs of these Huggies and things like that. Put it on them, and many a times when we see them, the child is there with the motion. And the child is not trained. Whereas earlier, when the child gets up after sleep, they take the child and make them put in their leg and you do a potty training. We're not going to beat the child, but just practice that. The child gets up, you make the child pass. So you have to start toilet training as early as possible. When the child is able to sit in the potty, you have to start. Next slide. So this I was telling you. To find out adolescents in whom bedwetting is not purely monosymptomatic, it calls for treatment. If it is non-monosymptomatic, apart from bedwetting, it has other things you need to treat. Next slide. Why? What all will you do? This one point you remember. Non-monosymptomatic enuresis, like if the child has leakage other time, etc., it will require appropriate treatment like management of a high pressure reflex, which will damage the growing kidneys. So, non-monosymptomatic aneurysms, you need to evaluate, treat, and safeguard the kidney. Next. The longer the aneurysm persists, the lower the probability it will resolve spontaneously, even though we say it has a 15% per year spontaneous resolution. Next slide. And you see it runs in the family. Next slide. And here, what are the main factors? Like pallu sollu later vandhu oru param. Otherwise, this is a maturation or developmental lag. The child takes more time to get adjusted. And the other thing is abnormal sleep. If you look into when you go and practice, you will know when you see children who come with nocturnal aneurysm, the history will be they will be deep sleepers. It will be difficult to wake them up. So there is an abnormal sleep. But if you put that REM, NREM, there is no difference. But overall, if you see, they will be deep sleepers. You won't be able to wake them up. Then other child psychology, environmental stress, organic tract disease, and abnormalities of ADH. This ADH is secreted in the night so that the urine concentrates. You have the circadian rhythm. And when there is abnormality, you have more urine secretion in the night. Next slide. Okay. So these three things, the brain, kidney, and the bladder. The bladder, it can be a reduced capacity in the night or overactivity. I put the picture, can you see Kumbhakarna? So remember, these kids will sleep like Kumbhakarna. Next. Okay, so we'll skip that. I will go too much, all these things. So there is a TNS control where either there is an equivalent defect which fails to inhibit episode contraction or an occurrent defect which fails to respond to bladder fullness of contraction. It's next. So, this is the monosymptomatic, solely nocturnal, normal physical examination, no need to investigate further. But it's non-monosymptomatic, daytime aneurysms, urgency dripping alarm, and refer. Next slide. So, the complete evaluation we skip all this. Okay. Management is a good toilet training. I discussed to you regarding the menace of diapers. But if persistent, you definitely need to treat. The behavioral therapy centers around good bladder and bowel habits. You have to remember that constipation is a very important aspect of avoiding dysfunction in both extremes of age, in the pediatric and the geriatric age. So you have to concentrate about the bowel habits also. Children should be reassured that aneurysm is not their fault and they should not be punished for bedwetting. They should not be put to shame in front of others. But you can utilize them in cleanup. So you can use them in part of the next slide. Avoid excessive fluids and bladder irritants beyond evening. Full tumbler milk at night or 8:39, definitely, the solid load is more, it's going to have more urine. And empty bladder at bedtime. Before going to bed, ask them to pass urine. Instructed to wake up at night and use toilet to remain dry and can use regular alarms for mobile and improve access to light. Next slide. Next slide. So other drugs. For bedwetting, desmopressin is a very good drug. It's available as mineral. 0.2 milligram orally before bedtime can increase up to 0.6. So adolescent bedwetting is around 1%. Do a detailed evaluation and need to know if there is any organic cause. Good bladder and bowel habits, alarm medications, and treatment should be individualized. So educate, reassure, and then just go slowly above. Next slide. Now, 9-year-old girl child with history of recent onset of bedwetting. Now, what category does this come to? Second, very good. Now, tell me, what all will you think of? The child had been absolutely normal till 9 years, was dry from the second year of age itself, but from 9 years she leaking. Next slide. So, it could be an unusual stressful event, parental divorce, sibling birth, organic diseases like urinary tract infection, diabetes mellitus, obstructive sleep apnea, conduct disorder, neurogenic bladder, everything. I want you to highlight sexual abuse. The poor kid will not know what to tell. She may be suffering from sexual abuse. So when you see children, have that in your back of your mind. Very different type of complaint. Anything around those vulva, always have, is there a sexual abuse? It's very high in becoming next slide. So secondary nocturnal enuresis in adults can be because of overflow. I was talking about prostate. Next slide. Or it could be an underactive bladder. Next slide. Okay, next slide. We keep off all this. Okay. Okay. So problem of enuresis is treated with 5P regimen. Place, patience, perseverance, passion, and a positive attitude. Enuresis is basically a symptom and not a disease. Intervention is justified for the psychological benefit of the child and family. Next. Now, case scenario 4. So, 52-year-old Mrs. K, para-free, living-free, all full-term normal delivery, menopause at 2 years back, now comes with history of involuntary leakage of urine for the past 2 years, and leak is associated with coughing, laughing, and sneezing. No urgency, no history of diabetes or hypertension. And physical examination, she is obese, around 84 kg, otherwise normal. Now, what type of incontinence will you follow? Very good. Excellent. Next slide. So, how would you evaluate a stress incontinence or anybody with incontinence? You should know duration of leak. Okay. How long has this happened? If a patient comes and tells you, I had a normal delivery about 8 days or 10 days back, the baby died, and I'm leaking of urine now. So, what type of incontinence could be this due to common leak? Kekala, Sattama. Fistula, due to obstruction. Yaar obstructed person Okay. So that you have to know whether any inciting events have contributed to the onset of leak. Good one. Then is a Sattama not a back of pelvic surgery. Did the leakage start after a strain, a fall, or a trauma? So incontinence about the history we can differentiate. Stressa, adjunta, mixeda, or following any surgery, you think of fistula. And it has mixed stress is the urgency which is more bothersome, you need to know. And whether how to quantify the amount of leak. Is the leak trivial or you don't have to go do great things about it. But it leaks terribly, affects her quality of life, her bothersome score is very high, then you need to do. There are intrinsic sphincter deficiency is a very weak sphincter. So if there is trivial stress, there will be marked leak and also leak with ventricular checks like that. So we need to know the voiding pattern. How is the urinary frequency? Can anybody tell me what are the obstructive urinary symptoms? Obstructive urinary symptoms. Ennalam. Nocturia is irritated. Frequency, urgency, nocturia, irritative. Lower urinary tract symptoms can be obstructive and irritative. Obstructive, for example, prostate. Tata obstructive symptoms obstructive dribbling. Incomplete iodine. Fullness of blood. No. Initially, they'll come and say difficulty in passing urine. Difficulty in passing urine. Then all your intermittency, hesitancy, need to strain, sense of incomplete. So, is there an obstructive symptom? Obstructive symptom is the urine leak or you have to think it is an overflow incontinence. And extreme fluctuate during void. Stricture, strain or is it the same? In prostate, if it is strain, it will not improve. And is it necessary to push or strain or change posture to void or empty the bladder? If you do something, the urine improves. Gynecological causes. This also is a pencil question. Pen question. In gynecological problem, if a woman says, I do something like this. I either push, strain, change posture, or do some maneuvers which helps me empty the bladder. Prolapse. Prolapse main prosidentias. So, the prolapse the whole cystocele and all the prolapse comes out of the introitus. So, it is below the urethra, anti-gravity. So, they find it difficult. So, they have to reduce it and then void. Next slide. So, and then you talk about lower urinary tract instrumentation, neurological symptoms. Bothersome score. I mean, how important is that symptom? Has she made any lifestyle changes because of that? Supposing, say, for example, a school teacher uses the board and got dust allergy. The moment she cleans the board, she develops cough and she leaks. It will be very embarrassing for her. So, how much does it affect her? Does the incontinence limit the individual faculties, or has she made lifestyle changes because of the threat of leakage? Next slide. So, history taking down on the Monday. So, obstructive, we knew how to ask, irritative, a good obstetric history, whether premenopausal, postmenopausal, surgical history, whether a previous pelvic surgery can affect lower urinary tract function, anti-incontinence surgery, prolapse, all this data. AP resection of the rectum can also result in neurology. Constipation. Constipation is a very important factor for avoiding dysfunction. It can act like a space occupier, flow, motion, which can cause incomplete emptying and can provoke involuntary contractions. Other history also, like neurological history, DM, radiation or trauma, and everything to ask. Next slide. Bladder diary. This bladder diary is a very, very important aspect of any urological problem. So we need to know how much they are drinking, how much they are passing at what time, and what were they doing at that time. Were they coughing, laughing, or they had a sudden urge to go. If they had a sudden urge to go, the urgency level. Coughing, laughing, and stress incontinence. What it will tell you is, it will tell you how much of urine they are producing or how much they are drinking. So these questions will come with frequency, urgency, and then dripping. But if you full count 6 liters that means they are taking too much of water. A normal person, it is enough if they produce roughly 2 liters of urine. So the more they drink, because many of them don't go to doctors for treatment. They go to WhatsApp, go to their neighbors, their servants, their next door neighbor. So any urological problem, the first remedy given by the rest of the population is drink a lot of water. So by drinking lots and lots of water, they drink up to 6 liters of water and they have more frequency. So we correct that, this will become all right. Makes sense. So on examination, look for any mass, tenderness, neurological examination, look for atrophy, cystocele, rectus, pelvic mass. Rectal examination. If you have BCR, what is BCR? Bulbocavernous reflex. Anybody will tell me? Okay. This is one way of assessing how the neurological aspect is. So if you stimulate the clitoris or the glans penis or stroke the medial aspect of the thigh, there will be reflex contraction of the external sphincter. This you know that the neurogenic arc is intact. In women, up to 30% can have an absent PCR, but still neurologically normal. But in male, it is not like that. If they are PCR negative, they are a neurogenic bladder. And again, in rectal examination, I was going on telling you, constipation. And never miss an examination of the rectum because you can diagnose a PA rectum also. Next slide. And cough stress test. This cough stress test is one important thing to find out SUI, cough stress incontinence. Normal gynecological examination, we make the patient empty the bladder and then come. But here, when you are examining for urinary incontinence, you have to make the patient examine a reasonably comfortably full bladder. Patient is asked to cough and urinary leakage, synchronous with coughing is observed. It is the commonest test and it's easy to perform. Similarly, what is this empty supine stress? Even in a near empty bladder, the patient coughs and still she leaks, the sphincter is really weak. It's called an INCONTINENCE. Next slide. So this is called Bonnie's test. Bonnie's test, what we do is in patients with prolapse, you have to examine the patient both in full bladder and empty bladder. You reduce the prolapse and then elevate the urethra on either side and now ask the patient to cough and see. If after you have reduced the prolapse and the patient is asked to cough, she leaks. Do this test at elevating the urethra. If she no longer leaks, then patient will benefit out of that. If a prolapse பாக்குறோம் prolapse வந்து யூரிக் whole mass வெளிய இருந்து அப்ப நம்ம காஃப் பண்ண சொன்னா கூட யூரிக்ல கீக்ல இருக்கனால லீக் வராது. So to correct that, we are reducing it. You reduce the prolapse and look for SUI. That's called occult stress incontinence. இது surgery benefit ஆகுமா இல்லையான்னு தெரியறதுக்கு you do this body test where you put 2 fingers and elevate. Earlier we were doing this to know whether bladder neck elevation surgery. Next slide. So the routine test, urine routine and microscopy, culture sensitivity, complete blood count, kidney function, and ultrasound. Doing in ultrasound, it is very important to look for PVR. What is PVR? Theatre theriyala. Not getting mother. Anybody? No. Okay. It's called post-void residue. Normally, ultrasound will be done in a full bladder. So after doing an ultrasound, you empty the bladder, ask the patient to empty the bladder and come back and assess how much of urine is retained there. Is the urine significantly retained or not? Now tell me, why am I going and giving so much importance to assessment of post-void residue? Yes, sir. Anybody? Patient is coming to us with incontinence, but I am assessing this post-void. Why? Pattama enche alaga sollu. Enama? Correct? You can be wrong, there is nothing. But you should tell me. Anybody? To rule out obstruction. Why? What will you know? How will you rule out obstruction? Scan machine edadala obstruction irukudana nama dana interpret pananum. Enna irundha obstruction nu kandupidum. Yeah, the second girl solriya, third girl sollu. Prostate irundha obstruction. Adu enna namakku kaamichu kudukum? You are correct. It will help us diagnose obstruction. Prostate can cause obstruction. What will tell you that it is causing obstruction? Why is it important? Suppose a patient is having a significant prostatic enlargement. Upon the post-void residue, it will go. Enama? Urine residue na kekra. Incomplete voiding, eppadi irukku kekra. You use little more words. Increased. The post-void residue will be increased. Normally, paravala, unbreakable. The third girl. Obey Nama. So you are correct, but little more you needed. But still, this itself, I'm very happy. Okay. So to see if there is a residual urine, then we think it could be an obstruction. That is one. Very good. If there can be one more reason. Even without obstruction, there can be significant residual urine and that can also cause incontinence. The question is, I've done ultrasound for her and I've done a post-void residue. The post-void residue 600 ml. Normally it will be 10, 20, 30, 40, even up to 1/3 we can make. But this post-void residue itself is 300 ml. One, you told obstruction, but there is no obstruction in this patient. So what else could you think of? Neurogenic. How does you correct? But you, enama? Ama, correct. Adanala, enna agudhu kekra. That it is a hypotonic. Paravala, you solradhe happy ba. So neurogenic bladder. There can be a hypotonic or a atonic bladder, where the bladder doesn't generate power enough to contract. So, the prostate is the patient hypertonic bladder, we surgery pannalu seriya varudhu. So, post-void residue will tell her whether there is an obstruction or there is a neurogenic component. How will you differentiate? It's a little too much, but there are some post-void residue adhigama irukku. It can be obstruction or it can be neurogenic. Any one test which can differentiate? Pair mattu sonninga po. Something related to urology. If you tell me just the name is enough. Next investigation. So, you know, the words are urology investigation. Tell you most part cystoscopy. Cystoscopy is hypotonic bladder obstruction. But both can be diagnosed in one investigation. Some urological investigation. Anybody? Enema? Pilo. URINARY. Blue. You got a clue. URINARY. Euro? Euro? Dialysis. Euro? Kekla. Manometry. Something closer. Anybody? Euro, the third word, after word is evaluation. Urodynamic evaluation. Urodynamic evaluation will assess the whether the obstruction or whether the generative cause. Next. So, do you do a cystoscopy for every patient with incontinence? No, only they have microscopic hematuria, either microscopic or visible or any pelvic mass. Next slide. So, when to do urodynamics? So, when you have an overactive bladder or whether there is any previous surgeries, the patient has already been operated and has not become all right. That is a difficult case. So, for that patient, you will do the entire investigative armamentarium. So, previous surgeries for SUI or obstruction or an unclear diagnosis or a mismatch between signs and symptoms or a suspected neurogenic bladder, you do a UDE or a urodynamic evaluation. What are the reversible factors for incontinence? Weight reduction, medical comorbidities like diabetes, hypertension needs to be optimized, postmenopausal vaginal atrophy treated with estrogen greens, UTI, genital infection. So, what will you do? Management of stress incontinence. First line of treatment is weight reduction and pelvic floor muscle treatment. And what is a medical line of management? This is not the first line of management. It is to be used only if the patient is unwilling for surgery. Use a drug called duloxetine, 40 milligram once daily. Selective serotonin or epinephrine receptor inhibitor. Then we can go for surgical management. So, what are the lifestyle modifications you do for an incontinence? How many more minutes do we have? 1 second. So, fluid management. Now, 5 liters frequency adjustment. So, correct the fluid. Caffeine reduction. This is for overactive bladder. So, anything which irritates the bladder, you must avoid. Other dietary reduction, bowel function, I emphasize many times. Obesity and weight reduction, smoking. Smoking is also seen in women nowadays. So, how will you make a decision? Depending on the patient's age and overall health, relative contribution of whether hypermobility or ISD, the cause, associated pathology, and experience with surgery. Next slide. When to treat surgically? In the patient force surgery. It must be patient driven. There must be significant bother or lifestyle compromise. The causes are adequately evaluated. Non-operative therapy is either unsafe or ineffective, and primarily SUI, and the patient understands the risks and benefits. Next slide. Who want not to operate? So, a patient who has a palpable bladder on bimanual or physical examination. So, it could be a neurogenic bladder, or it could be an obstruction, or if there is any history. So, So these are many conditions whom we should not operate. Next slide. So this is simple. When you are going to open up the patient for any fibroid, benign ovarian cyst or hernia, you can do pubovaginal stake. When you are going to do from below, you can do medial thrust. Next slide. I'm not going to make it very complicated. This is a burst, open burst, where you take anchoring stitches onto the Cooper's ligament. Next slide. And you have tension-free vaginal tape. Next slide. And this is an indigenous tape. The Johnson & Johnson tape comes around 40,000. This we get it around 5,000. Now next, 69-year-old. Here I will bring out that point which I said. 69-year-old widow who is obese, diabetic, bilateral osteoarthritis, suffers from increased frequency, urgency, and urge incontinence. Now, imagine obese, diabetic, bilateral osteoarthritis has got increased frequency, urgency, and incontinence. What all you do? Diabetic, I was going on telling you, you need to look into her sugars and control that. And phosphoid residue, whether there is a neurogenic. India is the diabetic capital of the world, and diabetes is a very important cause of a neurogenic bladder, like a diabetic cystopathy, where they don't empty the bladder. So we need to see that also. Next slide. So, this is step by pattern. Weight reduction and pelvic floor muscle training for both types of stress and urgency. You have a lot of drugs like oxybutynin, tolterodine, solipenicin, and dariphenazine. And the newest hit on the block is mirabegron, which is a beta-3 agonist. The combination is an FDA approved. Next. This is the first question. Why do I say it is potentially dangerous? This lady says running for fear of leakage of the flow. She's worried about her daughter-in-law or grandson, grandchild, anybody. The fear of falls and fractures. When this diabetic obese osteoarthritis runs to go to the toilet to avoid a leak, if she sustains a fracture like a femur, her whole life gets changed and she becomes potentially dangerous. So when you care for the elderly, avoid bladder irritants like caffeine, tea, soda. Keep pathways clear and bathroom clutter-free with lights on. Especially when you have your elder people at home, please make sure have some, CFL lights there. Make sure you provide regular bathroom breaks and use underwear that get on and off. And you always used to have good supportive caregiver. Next slide. So for the elderly also same. Only thing we have to avoid drugs which cross the blood-brain barrier. Next. So again, the 32-year-old ex comes with history of continuous leakage of blood for the past 2 days. Had a cesarean hysterectomy done for profuse bleeding and placenta previa. So the diagnosis is BVF. What are the other causes? I told you, neglected obstetrical labor, gynecological causes like hysterectomy, CA cervix, and post-radiation fistula. Compared to normal cesareans, cesarean done for placenta previa, placenta accreta syndrome can be little dangerous. They can have manual bleeding, need for hysterectomy, need for bladder injuries. We need to be more careful. Next slide. So, what are the risk factors for bladder injury as such during any gynecological or cesarean? Obstructed labor, distended bladder, previous cesarean, previous myomectomy, previous history of bladder injuries, and placental abnormalities. This number is increasing. That's one of my favorites. So, how to avoid a bladder injury? Keep the bladder empty. Before you do a cesarean hysterectomy or anything, see that the bladder is well catheterized. The bladder contracts, the muscle wall becomes thicker, so less chance of inadvertent bladder injury and sharp infection. So, if there is a previous cesarean, you can see that the bladder is drawn up and gets adherent. So, when you mobilize this, you have to be very careful and always what we say sharp dissection. Don't put a gas and sharp dissection will be better. Next slide. So, placenta previa, I told you. Next slide. Can you see the placenta? Next slide. And obstetric urinary injuries. Normally, the urethra is not involved during cesareans. But when not can it get involved? When there is an angle extension of the cesarean wound due to difficulty in delivery. In those cases, put an inverted T incision. Or when there is bleeding into the broad ligament and blind clamping can also lead. Cesarean hysterectomy is appropriate. Next slide. So when there's a suspicion of bladder injury, you can fill it methylene blue and you easily diagnose. Next time. Next. So 45-year-old para-3 TAH done, VSO done 1 week back, comes with history of clear watery discharge TB, no risk factors. Now, what other history do you want? Like you can ask any intraoperative difficulties, the quantity of leak, any normal. Again, this I want you to tell. This patient has had hysterectomy last week, is leaking urine, but she says I'm able to go and pass urine in the toilet also nicely. Diagnosis. So hysterectomy done 1 week back, able to pass urine normally. In addition, continuous urinary leak. Sattama solluvom. I am not able to hear. Fistula. What fistula? No. Uretro. Uretro yaar vaai tharalladha? Niya. Who said uretro? Come. Whoever said uretro, come. So, this is what you need to know. இப்போ 2 kidney 2 ureter இருக்கு ஒரு ureter damage பண்ணிட்டோம் வெச்சுக்கோ அது வழியா லீக் ஆகும் but the other kidney and ureter is normal it drains into the bladder she pass urine. So what are the causes other causes of clear vaginal discharge? It could be deviate ureterovaginal discharge normal vaginal secretion எவ்வளோ இப்போ ஈஸியா ஒரு hysterectomy ஆயிட்டு லீக் வந்தா what is the test which you can do which will diagnose எல்லாத்தையும் hysterectomy done, இது கூட நீங்க யாரா சொன்னீங்கன்னா எனக்கு one investigation only is allowed. Hysterectomy done 1 week back comes with urinary leak. What investigation will tell you? இதெல்லாம் வாழ்க்கையில ரெகுலரா பாப்பீங்கம்மா. அல்ட்ராசவுண்ட்ல சொல்லுமா கொஞ்சம் கஷ்டம். Intravenous pyelogram. Now, currently CT KUD. Okay, CT will clearly differentiate whether it is a VVS, it could be coexistent bladder problem with a single investigation of CT. But IVP also will. Okay, next slide. And I have put a picture. Can you see? Can you see the whole thing is a cervical fibroid? Uterus stomach in the patient koncham care illama panna what type of there is a uterus mele chinnada irukku the whole cervical fibroid is big. What injury if you are not taking adequate care? Ureteric. அது இன்னும் கொஞ்சம் எனக்கு give me extra words. Ureteric முன்னாடி ஒரு word add பண்ணு. Anybody? See, uterus is in the center. It is uniformly enlarged. It is not more enlarged to one side. Uniformly enlarged. So what ureteric injury will happen? Bilateral. Bilateral சொன்னப்பலவா? நீ பின்ன என்ன சொன்னியா? பின்னாடி சொன்ன யார் சொன்னியா வாரதா? வா வா இல்ல. வா. So what you should do is the UV fold of peritoneum is here. Correct. And then open body, push the bladder and make a decision. Enucleate the bladder. You will avoid a ureteric injury. So in cervical fibroid, you need to practice enucleation of the myoma after pushing the UV fold of peritoneum. Okay. This is the இது நான் ஒரு சைடா போட்டுருக்கேன் பாருங்க. This is okay, but இந்த சைடு எல்லாம் எலாஸ்டா மேல வா. அங்கெல்லாம் இல்ல. So this is a broad ligament fibroid. இதுல என்ன இன்ஜரி வரலாம்? இதுவே யூரிட்டரி. அந்த யூரிட்டரிக்கு இந்த யூரிட்டரிக்கு என்ன டிஃபரன்ஸ்? அப்படி சொல்லலாம். Unilateral. Unilateral first yaar solunga. First நீங்க யார் சொன்னீங்களா வாங்க. Joint தான் சொன்னீங்களா? John தான் சொன்னானா வா John. What do you want? I'm really happy. So in the question you open the retroperitoneum, enucleate the fibroid, and again you can avoid. So enna ஞாபகம் வச்சுக்கணும் broad ligament fibroid or cervical fibroid, enucleate the fibroid. அந்த cervical ஒரு ஸ்லைட் முன்னாடி போயே. இந்த cervical fibroid ஒரு இப்போ வந்து how all will you avoid urinary injury in gynecology in hysterectomy கேட்டாங்கன்னா apply clamps close to the uterus னு சொல்லி தருவோம். இங்க வந்து can you put close to the uterus you cannot இருக்கும் எங்க clamp போட முடியும். அதனால தான் அத enucleate பண்ண சொல்றாங்க. You understand? So one important factor how to avoid urinary injuries, apply clamps close to the uterus. And the sentence apply clamps close to the uterus, you will not have injury. In the cervical fibroid or the broad ligament fibroid is in the enucleate. Okay? If it is a cervical, UV folded through, UV fold open பண்ணி bladder தள்ளிட்டு அப்புறம் myectomy. அடுத்தது இதுனா இந்த retroperitoneum open பண்ணி broad ligament open பண்ணி fibroid. Next. Now 72-year-old lady who had a patient, diabetic lady operated for pelvic organ prolapse with by an excellent gynec surgeon. Presence with involuntary leakage of urine after 4th day. No normal void. Excellent gynec surgeon, diabetic. What is the diabetic? உனக்கு வேறதா வேணுமா எனக்கு கேளு. நீ clinical findings கேளு நான் சொல்றேன். இல்ல நீ diagnosis சொன்னாலும் சொல்லலாம். உனக்கு எப்ப நிறுத்தணுமோ சொல்லிடு. சரியா? யார் சொல்றீங்க? என்னமா? A 72-year-old parasitic living six. அதாவது எனக்கு ஹிஸ்டெக்டமி சொல்லி கொடுத்த மேடமே தான் பண்ணிருக்காங்கன்னு வச்சுக்கோங்க. ஸோ ஹிஸ்டெக்டமில அவங்க யூரிட்டர் போட்டு தரல, பிளாடர் போட்டு தரல. அதுக்காக தான் நான் அந்த வேர்ட் எக்ஸலன்ட் கைனக் சர்ஜன் எழுதிட்டேன். இன்னொரு நான் சில அடைமொழி கொடுத்துருக்கேன்ல, அப்போ கண்டுபிடிச்சு சொல்லி பார்ப்போம். நம்ம என்னெல்லாம் டைப்ஸ் ஆஃப் இன்கான்டினன்ஸ் சொன்னோம், அதுல ஏதாவது வருதா? இது ஸ்ட்ரெஸ்ஸா இருக்காது, ஸ்ட்ரெஸ் எல்லாம் சொல்லல, அர்ஜென்சி சொல்லல, மிக்சர் சொல்லல, வேற என்ன பார்க்கலாம்? யார் சொன்னது? ஓவர்ஃப்ளோ சொன்னேன். பை ஓவர்ஃப்ளோ கரெக்ட். ஆனா பை இதுல எந்த ஃபேக்டர்னால ஓவர்ஃப்ளோ இருக்கலாம்னு சொல்றேன்? டயபெட்டிக். இந்த ஓவர்ஃப்ளோ போறால டயபெட்டிக் சொன்னது போறாரு. டயபெட்டிக்ல எதனால? அப்ப கை தட்டுறது மட்டும். எனக்கு அந்த டயபெட்டிக் ஏன் ஓவர்ஃப்ளோ சொன்னேன்? Neurotic, hypotonic can have diabetic autonomic systemopathy where hypotonic bladder can be. Before surgery கூட உங்களுக்கு அவ்வளவு தெரியாது, but after surgery என்ன ப்ராப்ளம்னாலும் சர்ஜன் தான். சரியா? எக்ஸ்பிளைன். வேலை டிஸ்டர்பன்ஸ் எடுத்துக்கலாம். So how will you evaluate? Review of the clinical examination சொன்னேன். The clinical examination நீங்க யாரா சொல்லினா நான் bladder distance சொல்லிருப்பேன். இன்னும் ஈஸியா நீ ஓவர்ஃப்ளோ சொல்லிருக்கலாம். சரியா? அடுத்து imaging, review of the preoperative ultrasound. இது பார்க்கும்போதே they had written bilateral instrument with PVR of 300, but that surgeon வந்து did not see. So if you had seen that PVR is 300 at that time itself, you have to counsel the patient. You may not be able to pass urine after surgery. That depends on the neurogenic component. And bethanol is a cholinergic drug. It is not very often used. Explain. Urodynamic evaluation will tell you it's a hypotonic. So value of clinical examination. நீங்க யாருமே நான் எதனா கேள்வி நான் சொல்லுவேன்னு சொல்லல, நீங்க கேட்கல. So clinical examinationல full bladder ல overflow சொல்லிட்டு போறோம். Preoperative assessment of KV and PVR is very important. Possibility of diabetic systemopathy in patients with significant PVR should be considered pre-op and counseled accordingly and do urodynamic evaluation. அடுத்தது இது எவ்வளவு அது லாஸ்ட் ஸ்லைட். I mean time came. So this is another history which I want you all to carry on. So a 40-year-old lady was admitted in the hospital with complaints of involuntary leakage of urine for the past 1 month. associated with markedly increased urinary frequency both by day and night, and avoiding only very small quantities of urine and the symptoms of urgent incontinence. No history of stress, history of burning, nutrition on and off, no history of surgery, trauma, radiation, history of loss of weight, history of BP, rise of temperature, and bad in the budget. And if anybody tells me what I would have been happy to give in a clinical diagnosis. Some other India. Very good. This slide are very much interested. Patient had consulted nearby doctors for burning, nutrition, dysuria, increased frequency, and was treated presumptively with non-toxicin, flevoxate, and alcohol excess. She was given the same kind of treatment for 3 or 4 occasions, and hence patient continued to buy the same combination of medicine from nearby chemists and consume it whenever her symptoms were bothering her. Approximately, all frequency urgency dysuria is not urinary tract infection. Maybe some urgency dysuria you treat her. Believe me, you give one prescription, the patient will take it 20 times. So when you talk and you treat, you tell them, you need to see it back. But always you tell, please come for a follow-up, or if you're not becoming alright, next week. So, next slide. What is the time lag between pulmonary tuberculosis and genital urinary tuberculosis? It takes decades. So, chinna vayasu tuberculosis one. So, for it to it takes decades to come. So, we'll come. Go ahead. Go. I wanted too much. I wanted to show So tuberculosis leading out to thin bladder causing frequency amounting to incontinence is known to occur. In this patient, they came with VVF also. Next slide. So can you see? They have done a nephrostogram and put a contrast. Bladder capacity is so small. So because she has got contracted, the bladder has become a thimble bladder. So that is why she had frequency urgency. So whatever she had initial symptoms of frequency urgency was tuberculosis, which was missed. And it landed up in this. And hence, they had to augment with a bowel. Next slide. So frequency urgency dysuria can be present in urinary tract infections, stones, but could be due to other causes also. So beware, think of genital urinary tuberculosis, carcinoma in situ of the bladder also can come. So always when you treat, tell them, oh, practice pick up on it's better to follow up with the patient. Explain. This patient had undergone hysterectomy of a prolapse some 4 months back. Next slide. She came with white discharge for 2 months and history of urinary leakage for urine for the past 1 week. Hysterectomy done 4 months back. Urine leak for 1 year. We'll go fast. Next. Otherwise, surgery was uneventful. Next slide. Next slide. Next. Next slide. Next slide. Now, this was the ultrasound which showed some mass facial lighting in the bladder. Next slide. CT. Teresa. Next slide. Can you mark or tell me what it is? Mark the either mark. Correct. Very good. What is he trying to tell? Bulb okay, next slide, please. Next slide. So had a BBF also. Next slide. Yes. So I put in a scope. What is it now? This is into the bladder. Can you see? Tell me what it is now. This is into the bladder. Bladder ulla enna irukkum. Ennadhu idu? Enna pana illa but sollu. Huh? PA. Abada next patient. That is a fistula. Krida. And the இடத்துல opening. Correct. Super. I'm just putting that's a gauze mark. I'm putting a stone punch and taking out that gauze. Krida, using it and taking it. This is such a big gauze. So, hysterectomy nalla pannanga and anterior vaginal wall flap raise ஆகும்போது கொஞ்சம் bleed ஆச்சு ஒரு gauze அப்படியே உள்ள சொருகி விட்டாங்க மறந்துட்டாங்க. So, gauzy phleboma, very important to have a count of all the gauze and instruments. Okay. Thank you and stay safe. Wish you all the best in your career. Do well. Do extremely well, whatever field you take, whatever you do. My real good wishes to all of you. Have a nice day. Thank you.
Thank you, ma'am. Thank you, ma'am, for the interactive session. It was a great learning from various case scenarios. As a token of gratitude, I request our academic secretary, Gurureli sir, to present Dr. Srikala Prasad ma'am with a memento.
I feedback from you all so that subsequent teaching classes, what you all want, what you all don't want, you can message to Pugadeli. I will take it from him. It can be with name or without name, doesn't matter. Pros and cons, what you want, what you like, what you didn't want. Okay? Thank you. Have a great day.